This video is about total knee arthroplasty. Typically when patients show up to my office who may be in need of a knee replacement or total knee arthroplasty, they'll come in complaining of knee pain and likely stiffness and difficulty with normal day-to-day activities. Sometimes patients will require the use of a cane or a walker device because the knee pain has gotten to be so difficult for them to ambulate. When you come to my office, we'll perform an exam where we look at the range of motion and evaluate all possible causes for the knee pain. The most important study that we get for knee replacement is X-ray. This knee arthritis can be diagnosed strictly on X-ray. And what we see on the X-ray is we see decreased joint space, or the space between the bones narrowing. And what that signals to us is that the cartilage is thinning. So an X-ray just shows us bones, and when we see space on bones, that space is equivalent to cartilage. And as that cartilage thins, the bones get closer and closer together. Oftentimes you'll hear people refer to bone-on-bone arthritis, and that's indicative of an X-ray finding in which the bones are stacked on top of each other because all of the cartilage is lost. Once this diagnosis is made, we initially start with non-operative management. The best non-operative management for osteoarthritis in the knees would be, number one, weight loss. The less you weigh, the less pressure is going to be on your knees, and that's probably the most important thing to reducing knee pain. Next, we can try anti-inflammatories or Tylenol to help with the pain control. A lot of times we'll often get started in physical therapy to work on strengthening around the knee and also increasing range of motion. Lastly, we can use different types of injections in the clinic. And the most common thing we'll use is a corticosteroid injection into the knee. And that's a very cheap, easy injection to perform in the office that all insurance companies will pay for. This acts as an anti-inflammatory in the knee and can often give patients really good relief. There's another type of injection that most insurances will pay for after we get approval, and that's what we call viscosupplementation. Sometimes you'll hear people refer to this as a gel injection or a lubricant injection. There are several different types, and this is an injection that's usually in a series of 3. So you'll come to the office 3 straight weeks and you'll get that injection. This lubricant, it can act as a lubricant in the knee to help it move better. It also has certain molecules and properties in it that help to normalize the chemistry in the knee and hopefully provide a pain-free knee for some amount of time. The insurance companies will typically pay for this injection every 6 months, so a patient can get this injection every 6 months and get steroid injections in between. At some point, when the pain gets bad enough and it's starting to affect patients' day-to-day activities and quality of life, that's when we would discuss a knee replacement. For arthritis, a knee scope is not going to work very well for the treatment and will not provide long-lasting comfort, and a knee replacement is really the only option. In a knee replacement, we're taking all the weakened cartilage and bone off of the knee, and that's off both the femur and the tibia, and replacing it with metal parts. There's then a plastic piece that fits in the middle and acts to restore the knee joint and allow for function going forward. Typically, this surgery lasts anywhere from about 60 to 90 minutes, and right after the surgery is done, a patient will immediately start physical therapy in the hospital. The patient will get up and walk with a walker on that very first day and start to work on range of motion of the knee. Some patients will do this as an outpatient procedure and go home the same day, but every insurance will pay for a one-night stay in the hospital, and that decision will be made by myself and the patient and the patient's family. If a patient stays an extra night in the hospital, they'll again work with therapy the next day before being discharged home, usually before noon the following day. While at home, a therapist will come to the patient's house for about 4 weeks. They will work on ambulating first with a walker and then quickly progressing to a cane. And hopefully by 3 to 4 weeks, patient is ambulating with no assisted device. My goal is by 6 weeks post-op for a patient to be ambulating with no assisted device and no limp. The patient will follow up with me, usually 3 weeks post-op, and we'll check the incision and make sure that everything looks good in the knee and that the motion looks good and that the patient is ambulating okay with minimal pain. At that point, we will usually get the patient into outpatient therapy. So after 4 weeks of therapy coming to the house, you will then do about 6 weeks of outpatient therapy in which we work on continued range of motion, strengthening, and comfort with ambulation. Typically, I consider a patient healed at about 10 to 12 weeks post-op. The patient can then go back to any type of job with no restrictions. If a patient works a desk job, I usually recommend taking about 3 weeks off before returning to work. If you work a middle-of-the-road type job with not super high demands, then I typically recommend taking somewhere between 6 and 8 weeks off. And if you're a more high-demand worker like a construction worker, police officer, or fireman, I would recommend taking at least 10 to 12 weeks off before returning to work. Overall, patients continue to improve quite a bit for the first 6 months after surgery, and most of our studies show that patients get better for even a year following the surgery. I'll typically see patients at the 3-week follow-up, at an 8 to 10-week follow-up, and then typically at a 1-year follow-up. If a patient needs to be seen anytime sooner in between those dates, that can be arranged as well.